Good afternoon, good morning, or good evening whenever you're watching this. My name is Jody Scholes. I'm your instructor for the MBLEx review class. I am so happy to be here with you as a massage school graduate. You are my people. Even though I don't know you personally, I know you. I don't know if you can see me tapping, but I know you. Yeah, I know you in your heart of hearts because not everyone is called to this work. It's a special person who's called to this work. And so I just want to say thank you for listening to the call of your heart. Thank you for going beyond being curious to actually studying this material, to getting yourself ready to be a licensed massage therapist. I've been on this path for over 20 years, doing work. I still practice massage therapy. I had 2 clients yesterday. I have a client today, and I love the work. And I love supporting you getting ready to do the work. Um, and so our class today is about MBLEx. So thank you for being here and getting yourself ready for this gnarly test. Yeah, it is. It's a rough one. Yeah, it is. It's a tough test, and we're going to learn about the test. So part of what you learn here in this class is not just the content. So yes, we have to know content, but also what I'm sharing with you in 3 parts of class. The first part is test taking strategy, and that's what most of us didn't get in school, which was test taking strategy. Really understanding the nature of this test is going to equip you so much better to be ready to calmly, confidently, peacefully pass this test. So we're going to talk about test taking strategy. We spend the majority of our time in part 2, which is the learning. We have a big body of work to cover today, which is just navigating the body, understanding the directional terms of the body, anatomical terms of the body, movement of the body. Um, that is going to be a big part of your client assessment questions. Uh, we'll take a look in a moment just about what's actually on the MBLEx. But the third part of class is dissecting questions. Because when we get into taking that test, many of you have already taken the test, and you get in there and it's like, what in the world is this question about? I'm gonna give you some tools on how to dissect questions, how to pull them apart, and really understand what the question is asking, getting down to the nitty-gritty of how to find the best answer. So we spend some time dissecting questions because that's also part of your test taking strategy. Yeah. So let's get right to it. I want to share with you today. I'm going to share my screen. I want to show you exactly what's on the MBLEx. Now, some of you may have seen this before. Here we go. This is from the Federation. It is exactly what is on the MBLEx. There are 7 categories. You'll see here A and P, anatomy and physiology, kinesiology. Right here we see pathology, special populations, benefits and physiological effects of massage, client assessment. And that is what we're covering today. We have a whole nother module on client assessment, but today we're laying the foundation for our client assessment and our anatomy and physiology by navigating the body. We're going to go over some terms for navigating the body. You'll see here overall view of bodywork and massage modalities. So what else is out there? So we no longer have the history of massage. This is not correct. This is an old, yeah, let me go to FSMTB because this is not up. Let me show you the actual and how to get there. So if you want to go find this, you go to the Federation's website. Hopefully this is changing for you and not static. If it's static and you're still seeing that outline, please put a note in the chat. But here you'll go to MBLEx. You'll go to exam content. And under this wordy category, there are a couple of hyperlinks. You can see the content in Spanish and you can see the content in English. This is the proper form. So here we see A&P, kinese, pathology, benefits, client assessment, like we've already talked about, ethics and boundaries. There's no more massage history. No massage history. You don't have to know any of the history of massage. So Pearl, Ling, Pearl Heinrich Ling, all of that old stuff about where massage came from. They start, anyhow, doesn't matter. So that is, you can learn it for your own knowledge. You probably learned it in school, but they have replaced it and added to categories, ethics and boundaries. They added on to that. They added on to guidelines for professional practice. Right beside here, you see this little 15%. That means 15% of the questions on your test are going to be about guidelines to a professional practice. We wonder, what does that have to do with actually doing a great massage? It has to do with professional practice. It has to do with you operating and agreeing to paying your taxes, to keeping your notes secure, to draping. You'll see it goes into exactly what's there: business practices, record keeping, healthcare terminology. We have a whole module on this though. So as you are studying on your own, my recommendation is to do meaningful homework. Meaningful homework starts with understanding what's actually on the test. And if you go through this and you see something that you don't recognize, a word you don't recognize, a category you don't recognize, that would be a good place to start. A good place to start is this content outline and just seeing, is there anything in here that doesn't look familiar? For example, down here under pathology, classes of medications. Did you study that in school? How familiar are you with medications? In our pathology class coming up in a couple of weeks, we cover all sorts of medications, the prefix, the suffix, how to identify medications. And we don't spend a whole heck of a lot of time on medications because look here, 14 questions, 14% of 100 questions, so 14 questions are going to be on pathology. Only 14. So if you spend all of your time studying anatomy and physiology, guess what? How many questions are going to be on A&P? 11. Now, all of these categories kind of leak over and they blend together, right? Anatomy, physiology blend into kinese, which blends into pathology. So there's a lot to study in there. My point is, don't get hung up on one subject. Look at this, and to do meaningful homework, meaningful studying, is to understand what you don't recognize or don't know on this content outline and start there first. Okay? Excellent. That is my helpful hint on strategy for the MBLEx for this session. We're going to move into our actual learning now. This is going into part 2 of our topic today. It's easy. I mean, do you remember when you went to massage school and you spent a couple hours in class and you were like, oh my God, we spent 2 hours in class today? Well, it's easy to do. It's easy to do. And we have an hour to actually go through some of this learning. So that's why it might feel like we're moving through this material quickly, but we are recording. And so this will be posted on our patron site. And on the patron site, patreon.com/Jody Scholes. And you can always go through this material again, slow it down. There we go. So I want to give a shout out to Trail Guide to the Body. Thank you so much. Great textbook, very detailed. You can get really in the weeds with this. But I want to give them a shout out because this is the images that I'm using. Many of the images I'm using today are from Trail Guide. We're going to begin in navigating the body with what is anatomical position. And so if it's safe to do so, you could even stand up and get into anatomical position. This image here is of a female figure standing with her feet hip width apart. Feet are facing forward. Arms are hanging at the side. Palms are facing forward. Thumbs are out to the outside. You'll see here. And that is considered anatomical position. When we look at navigating the body, we always start from anatomical position. So if they are asking, if you get a question about client assessment or kinesiology, movement of the body, it is always starting from anatomical position. I say always, obviously it depends on the nature of the question. If it's a sports injury question, something out of the scope of answering a location question, just know that we start from anatomical position almost all the time. And here's 2 directions of the body. We'll cover a few more directions here, but while we're in anatomical position, we're looking at proximal and distal. Proximal and distal typically have to do with the limbs of the body. We see an arm here, and proximal and distal. So we start from the midline of the body, so right from that very center of the body. And if something is proximal, it could also be considered higher, but it is also away from. So usually we're using these terms with limbs. Look, in this case, proximal. So again, mostly with limbs, we're dealing with proximal and distal because we're moving away from, up from. So the shoulder is proximal to the wrist. That is the best answer. Now, if we'll see a few different directions of the body as well, but take a look, and the wrist would be distal to the shoulder. We do need to be careful with these questions, with these directional questions. What is where? So when you look at the ankle, and we say the ankle is blank to the hip. The ankle is blank to the hip. So the ankle is actually distal to the hip. The hip is proximal to the ankle. Okay, proximal and distal, mostly to do with limbs. Let's take a look at the different regions of the body. We'll start with, and if you've worked navigating the body with me before, hopefully this is a review. And this is a condensed review from what you've learned in school. So we're just going to go through these regions. We've got the cranial region. Cervical has to do with our cervical spine. We've got the thoracic region, having to do with our thoracic spine, and the lumbar region, having to do with our lumbar spine. But let's go in order. Cervical, cervical spine. Acromial, the shoulder area, the acromium process. That's the acromial region. Scapular, having to do with the scapula. We've talked about the thoracic region. Lumbar, sacral, pelvic. That can be left or right, the pelvic region. Let's move over to the hand of the male figure on this kind of right side of the male figure. The carpal region has to do with where the carpal bones are. Remember carpal tunnel syndrome? The carpal region? Yes, it's the whole region. Not just see on the female figure here. That's where we usually, as a massage therapist, access the carpal bones through the transverse ligament. Right here, the carpal transverse ligament. Right here on the right, it's the left hand of the female figure. But we're seeing the carpal region. It's either superior or inferior on the top or on the bottom, but that's the region. We have the dorsal part of the hand. We'll see a little bit. We'll look again at dorsal and palmar, dorsal and plantar in just a moment. But dorsal, the top part of the hand. So we've got digital, where the fingers are, our digits, our digital region, the gluteal region, popliteal. Do you remember that from school? That is directly behind the knee. It's the soft spot, the popliteal region, and that is a endangerment site or an area where we don't massage, right? It's called an endangerment site. There's another word for it that'll come to me shortly. But the popliteal region would be a region that we don't massage. We massage the outsides of the knee. The insides and the outsides of the knee are beautiful to massage, but not that soft spot because there's no protection. Very much like the inside of the elbow, the antecubital, here on the inside of the elbow. Again, a contraindication and endangerment spot. All right, popliteal. Let's move over to the female figure, the pectoral region, the axillary region. Do you remember the axillary region? It's the armpit, right? The axillary region. We've got the brachial region, which refers also to the brachial plexus. This is where um, the brachial plexus comes through here, that bundle of nerves. The cubital is the pointy part of the elbow, moving in alignment with these words, abdominal region. The inguinal region, where the inguinal ligament lives. Also a little bit up here would be where the psoas lives. We've got the pubic region, the femoral region, the femur, right? That long bone of the upper leg. The femur gives us the femoral region. Let's move to the opposite side of the female figure, facial region, the mandible, the mandibular region. They make this stuff up. The subclavicle, excuse me, supraclavicle, see supra right here? Supraclavicle, supra above, right? Superman flew above, flew above the clouds. Supra is above, supraspinatus is our highest. Supraspinatus is our highest. Yes, our highest rotator cuff. Supraspinatus, we'll look at where that lives in just a moment. We've talked about the antecubital, the elbow, the inside of the elbow. Here we have the palmar region. Makes sense, right? Our palm. The patellar region, patella being the kneecap. The crural, you won't probably ever need to know that, front of the leg. But on the foot, the dorsal and the plantar surfaces. Yes, the regions. The dorsal region, you see how I have it circled in red? That dorsal region is the top of the foot. The plantar region is the bottom of the foot, the underside of the foot. Now, I point that out because there's, if you know any of the anatomy of a fish, for example, the dolphin has a dorsal fin. That's a dorsal fin right on the top of, and that's one way you can remember the dorsal plane of both the hand and the foot. It's the top. Just like that top fin sticks off the top of the dolphin, that's our dorsal surface of, and that's just called a dorsal fin. It's the top surface of our foot and our hand. We've covered those regions of the body. I don't think I have another slide for you, but oh, the brachial region. Yeah, good to just know that brachial plexus. If that's new for you, this is the entire brachial plexus, and we want to know about this for thoracic outlet syndrome. It's a pathology that we'll talk about another day, but thoracic outlet syndrome has to do with the brachial plexus, the brachial region. It's an impingement of all of these nerves that run down through the shoulder area. So it involves the scalene muscles, right? These scalenes. Isn't it fun to get some anatomy in with this? So our brachial plexus right here, that bundle of nerves. The clavicle, it goes under the clavicle. We got a pec major muscle here. I'll name this as subscap. I don't love where it's placed. We'll see that in a different way later on. But subscap is involved. The subscapula muscle, where do you think that lives? Above or below the scapula? If it's the subscapularis. below, right? So it's under the shoulder blade. Yeah, we'll see that later. And then here's a little edge of the scapula. But just so you know where that brachial region is, it's interesting because of the brachial plexus and the thoracic outlet syndrome, which is a pathology. That's why it's of interest to us. Let's look at the planes of movement. All right, I'm going to take a little sip here, pardon me. So this is my fancy cup. Show it to you. It's fancy because it's old. It's 1977. Yeah. Y'all weren't even born yet. This cup is older than most of you. How fun. I'll tell you a little bit more about the cup later. All right, planes of movement. Planes that we are identifying. Let's take a peek. Sagittal. Sagittal to me sounds like saddle. Sagittal. If you're in a saddle, look at this sagittal plane, okay? How it divides you in half. This way, down the middle. The sagittal plane is right down the middle, as if you were sitting on a saddle. Right there. Frontal makes sense, right? It's front and back. So the frontal plane defines anterior from posterior, the frontal plane. And then we've got the transverse plane. You see right here, cuts you in half, right under the belly button, right under the umbilicus, the belly button, right here, transverse. Transverse, it's nice and flat, that transverse plane. Yeah, so it cuts us in half. Directions, we've looked at superior, above. So my head is superior to my feet. My knees are inferior to my shoulders. So this is, we're moving along usually the midline plane when we're talking superior and inferior, okay? Now, there's a weird one called cranial and caudal. Mostly we only ever hear of this with animals because technically the caudal is the tail end. So that caudal end you see here on the horse and cranial. But as humans, we do have a cranium, right? So we learn cranial and caudal. So cranial is it's similar to superior and inferior, but more so it has to do with the tail end. So the caudal, if you see that word, they're talking about your tail end. Usually it'll be like a movement question, but probably won't ever have to know that. Hopefully you won't ever have to remember that. All right, one more thing about anatomical position. We move from the midline of the body. Closer to the midline of the body is medial. In the middle, medial, middle, right? If it's medial, it's closer to the middle. Lateral, it's outside. If you've played sports, you might have played laterally to a player. You might understand, have heard that term before, but it's farther from the midline. You're farther out. Likewise, superior and inferior have specifically to do with that kind of that zone of the body, that midline of the body when we're talking superior and inferior. All right, we've looked at proximal and distal, but let's use the midline of the body to define some movement. So there's two terms, abduction and adduction. Abduction, meaning you're moving away from the midline of the body. So to abduct, abduct is to move away from the midline of the body, out. And I've misspelled adduction here on purpose because when you adduct, you're adding to that midline of the body. You're adding to, you're bringing back, you're moving in towards the midline of the body. So you're adding to that midline of the body as you adduct. But now here's something tricky. Adduction can also be crossing the midline of the body. So when I worked with Major League Soccer, as the massage therapist for DC United, the adductors were always a problem. I mean, well, you can't say always, right? But I would say in 95% of the professional soccer players that I worked with, adductors were tight. And it's because of this movement, right? Right here. See how this leg is crossing the midline of the body? It's activating those adductors. Some were weak, some were strong, but they were almost always tight. So adduction is not only adding to the midline of the body, but sometimes crossing that midline of the body. And you'll see abduction moving away from the midline of the body. All right. Let's go through some other movements of the body. We have extension and flexion. We'll see this again and again, and it's going to sound a little repetitive. Extension and flexion. We see here adduction of the hips and abduction of the hips. We've got some medial and lateral rotation of the shoulder joint. So what is the shoulder joint? Put your hand on the shoulder joint. That is actually the glenohumeral joint, right? Don't ask me why gleno, I really don't know. Humerus is the long bone right here of the upper arm, but the glenohumeral joint, if you know gleno, feel free to put that in the chat because I actually don't. So the glenohumeral joint here, and we're keeping our elbow close to the body, medial rotation. Medial rotation, bringing that in, right? Medially rotating the head of the humerus. So the head of the humerus, medial rotation versus lateral rotation. Yes, very good. Now we also not only have medial and lateral rotation of the glenohumeral joint, the shoulder, but we also have rotation of the spine. That is not necessarily medial or lateral. If you're sitting in your chair, keeping both sit bones on your chair, turn your shoulders to the right. Don't lift your hips. This is medial rotation of it's rotation of the spine. It is rotation of the spine. No medial, no lateral. It is simply rotation of the spine. Careful with these descriptions, right? Figure out what's actually rotating. If you get a question about which muscles are involved in this rotation, make sure you know what is rotating. So if you're rotating the spine, that's very different than rotating the shoulder. Medial, lateral. I know you're with me. Okay, good. Let's look at a few more movements of the body. There's a movement called circumduction. And that is just a big cone shape. So if you're to move from this point, it's one fixed point, making a big circle, which basically is like a cone, an ice cream cone. This would be the bottom of the ice cream cone, or just a cone shape. Yeah, circumduction is the name of that movement. Now, here's something interesting. Neck. Lateral flexion of the neck. Bring your ear to your shoulder. Okay? Ear to shoulder. That is lateral flexion of the neck. What else can we do though? We could go like this, right? That is not lateral flexion of the neck. The neck is staying neutral. Laterally flexing the neck. And we go over this because if you have a question on the MBLEx that says your client is experiencing discomfort with lateral flexion of the neck, this is not lateral flexion of the neck. This is lateral flexion of the neck. All right, we'll get into more movements of the head and the trunk momentarily, but let's just look at elevation and depression. Elevation of, go ahead and elevate your scapulas. Now depress the scapulas. Elevate your shoulder blades, bring those shoulder blades up, shoulders towards the ears, depress, depress, yes, bring them down. We also see this movement for the jaw, elevating the jaw, but it's actually depressing. Once you depress the jaw, you can elevate the jaw. You can also clinch. This is depression of the mandible, right? You see right here in this picture, depressing the mandible, jawbone, mandible. Very good. All right, one more, supination and pronation of the forearm. So easiest way for me to remember is if I was holding a bowl of soup. If someone said, would you like some soup? I'd say yes. No soup for you. Ah! Yeah, okay. But would you like some soup? Yes. You would have to do this with your hand, right? Please give me some soup. Yes. And so that is supination. That is the movement of supination of the forearm. So some people would say it's opening the doorknob. Depends on the doorknob. Pronation of the forearm. Down. Pronation. Pronation. Right? Emptying out that bowl of soup. No soup for you. Pronation. Ah, yes, I would like some soup. Okay. I know it's corny, but I have to think of ways to remember this stuff. Because if I'm just trying to memorize, then there's no application of it. And what's the point? The point is, if you get a client assessment question that says your client is having pain with supination, then you're going to be able to supinate and identify what muscles are involved. Yeah. This is the scapula. We elevated and depressed our scapula, but I wanted to mention where your rotator cuffs live. Do you remember? SITS. So sits. We're going to pause here for a minute. So the sits. In fact, I'm going to stop my share because you had a chance to take a peek. All right. SITS. What does it mean? Do you remember? All right, let's go back. It is the acronym for your rotator cuffs. So the supraspinatus, the infraspinatus. So here we go. The supra, this is a shoulder blade, by the way, a scapula. So the supraspinatus lives right in this little groove. It's supra, it's the highest one up here. Infraspinatus lives right under here. And technically it originates out of the infraspinatus fossa. Fossa is just a fancy word for a divot or a gap. This is the interosseous fossa, infraspinatus fossa. So it's just where the infraspinatus lives. It's in this little gap underneath this, which is called the spine of the scapula. Some of this sounding familiar? Yeah, okay, good. We've done elevation and depression. We're going to move a little bit more quickly. Here's neutral, elevation, depression. Ooh, let's do these. I love these. And then within about the next 5 minutes, we're going to get into dissecting some questions. Just about that at that time of day. All right, movements of the feet with your feet. Go ahead. And what is this movement? What is this movement called? It's not on your screen. You can't see it. What's it called when you turn your feet in? There's a clue. Starts with, yes, it's called inversion. So inversion. So inverting the feet turns the feet in, and extroversion, eversion, eversion of the feet. So eversion is figure 1, 2, 6. Eversion. Thank you. Bye, Reva. See you soon. Eversion of the feet. And Now, what happens when you invert your feet? What muscles shorten? Tell me, what muscles are getting shorter when you invert your feet? What muscles have to pull? What muscles have to contract? How do you pull up the inside of your foot? You don't have to tell me what muscles, but just tell me where they are. Where are the muscles? Are the muscles on the inside or outside? The medial or lateral side of your leg? On the lower leg. So the lower leg, when you invert your foot, whoop, you're turning the soles of your feet towards each other. What's getting short? The inside of your leg or the outside? The medial side or the lateral side? Have the answer in your head because I'm going to give you just a second. Inside of your leg, the medial part, outside of your leg. What's getting shorter? The medial side. Whoa. Okay. I didn't say tighter because you're stretching the outside of your leg, right? You're stretching that outside, that lateral side of your leg, but it actually has to get longer. It has to get longer on the outside of your leg for the inside, the medial side. The lateral side has to lengthen, the medial side has to contract. Vice versa for eversion. So if you can evert your foot, it's hard to do that, right? To evert your foot, but just try. Try and bring up your pinky toe. You feel like the outside of your leg, touch the outside, the lateral part of your lower leg. Feel how hard it is? Those muscles are contracting. They're shortening, they're pulling. If it was a pulley system, if you were a puppet, we'd be pulling up, right? That pinky toe. So it's getting shorter on the outside, the lateral part of your leg. That means the medial part has to give. It has to has to lengthen. And when we have an imbalance in our muscles, then it's hard for the medial and lateral part to work together if there's an imbalance. I'll leave it at that. Let's take a look at the foot. This is plantar flexion. So plantar part of your foot, right? Remember we learned the bottom part of your foot is the plantar. You might get plantar fasciitis in the bottom part of your foot. Another common ailment of the foot is Achilles tendinitis. Achilles tendon on the heel, right above the heel. But this is the plantar part of your foot, the plantar flexion. And this movement, taking your foot off the gas pedal, lifting those toes up, dorsiflexion, dorsiflexion. Now I hear some of you dancers out there, some of you people who have taken any dance, you might say, Jody, that's point and flex, point and flex. It is point and flex when you're in dance class. But when you're talking about anatomy, it's plantar flexion and dorsiflexion. Now your question may say, if you point your foot, what muscles are you using? And typically pointing the foot would be plantar flexion because we're pointing, right? Just like we're pointing our finger, we'd be pointing our foot. Yeah, but just know the bottom part, that movement down, pointing the foot, that's plantar flexion. We're engaging, we're flexing our plantar muscles. And dorsiflexion, bringing that foot up. And this is another nice reminder. Supine is face up, prone is face down, and side lying is on your side. Couple other movements here, and then we'll move into dissecting some questions. Protraction and retraction. Protraction, stick your chin out. Retraction, bring it back. Good thing to do every now and then if you sit at a computer or drive a car for any length of time. Retract your jaw. Now I'm actually retracting my head, my cranium. I'm bringing it back because we tend to do this forward head position, right? So I am bringing my head back, but with the jaw, we're going out for protraction, in for retraction. And when we talk about that movement, we're typically talking about the mandible. And we have deviation, lateral deviation of the jaw as well. Lateral deviation of the mandible. And one last movement, opposition. That is another. And we learn these movements, we learn these words to help understand questions. so that we fully understand what the question is asking. All right, let's see where we are in our PowerPoint presentation. I am going to just take a quick peek. Okay. At where we are in our PowerPoint presentation to make sure that we get to our questions. Okay, well, we're going to get to our questions because it is that time. I like to tax your brain in another way. All right. So we're moving right along. Let's dissect some questions. Yay, that was great work. Great work. Oh, I told you I would tell you a little bit more about my mug. It's from England, and I unearthed this mug in from the items that I own, and when I saw it, I decided to use it because it was my inspiration for my TEDx talk. My TEDx talk was out of London. It's called The Body Blueprint: How Your Pain May Be Telling a Story. And while I was preparing for it, I decided that I would drink out of this mug, out of this little cup. It's a tiny little cup, look, comparatively. This is water. It's a tiny cup. But it's probably a teacup. But of course, I'm American, so I'm drinking water. Excuse me, I'm drinking coffee. But this was my inspiration, and I share that with you to encourage you to find something you can touch that is inspiration for you. I mean, yeah, sometimes in my pocket, I carry a crystal. Maybe that would be inspiration for you. This happens to be a rose quartz. It reminds me to come from my heart space. This is rose quartz. Yeah. And so find something that is an inspiration for you. So maybe you have a special pen or a clock or a cup that that is your signal to yourself that you are studying, that you are setting the intention. You're quietly but intentionally, strategically setting an intention. Every time I drink out of this mug, out of this cup, I am telling the universe that I am ready to do my next TEDx talk, that I am so grateful to have done my TEDx, but I am ready for my next TEDx as well. Cheers to that. Okay, so mindset. I saw maybe a comment come up. Oh, yeah, good. Maybe that's your thing, Melissa. Grab a rose quartz. Yeah. All right. So I pause there to say that we do a lot of learning, but a big part of success of the MBLEx is mindset and setting your intention. Setting your intention for yourself, but then having a ritual, having a process. Maybe it's every Saturday at 8 a.m. you're studying. That becomes your new normal, your new habit. By doing so, even with items like your cup or when you see 11:11. Have you heard that? 11:11? That's like a magical time of day. Maybe you set an alarm. I used to set an alarm on my phone for 11:11. And when it was 11:11, boom, the alarm would go off. I would pause. I call it stop, drop, and pray. What am I affirming? It was my reminder. Who am I becoming? Who am I being? Am I being who I am becoming? All right. Let's move on to dissect some questions. That's what we're here for, right? All right. Let me hide this. In Western anatomical position, the human body is blank. The human body is, let's see what they're asking. Okay, we covered anatomical position, right? What is it? Standing erect, facing forward, arms straight out, palms facing forward. Standing erect, facing forward, arms at the side, palms facing forward. Oh, arms at the side, arms straight out, palms facing forward, arms. See how that goes? See how it gets crazy and confusing? So I'm on letter B, standing erect, facing forward, arms at the side, palms facing forward. C, standing erect, facing forward, arms at the side, palms facing back. D, standing erect, facing forward, arms bent at the elbow, palms facing up. Okay, today we're going to learn about distractors. Every question that you get on the MBLEx, can't say every, the majority of questions you'll get on the MBLEx have distractors. That means there's something in the question that's distracting you. Distracting you from getting to the best answer. Take a look at these. Do you have a guess right now? You don't have to answer yet because I want you to see the distractors. Okay, we know you're standing erect. We know you're facing forwards. Take a look at this. Palms facing backward, palms facing up. Those are not anatomical position. D is distracting. Yes, exactly. But take a look at it because it's saying this, arms bent at the elbow, palms facing up. Now that you know anatomical position, what describes it? These two are distractors. They're meant to distract you from the best answer. They're close to right. They're actually 3/4 right, but they're not right. Okay, let's take a look. We know those two aren't right. So out of A and B, and this is what I want you to do with your test, okay? I want you to go through and find those ones you know are wrong. If you can, find two. Find at least one. But try and find two that you think, nah, there's not right. Then you have two that you think might be right, that are probably one of the two are the best answers. So in Western anatomical position, is anybody thrown off by this Western? Western? What does that mean? Western? Just in the West? Just in California? No. They're referring to East, like the East, India, Asia, Ayurvedic medicine, medicine of Eastern philosophy, versus West, Western medicine, Western philosophy. So, Western anatomical position, that's what we've learned. A or B, standing erect, facing forward, arms straight out, palms facing forward. B, standing erect, facing forward, arms to the side, palms facing forward. Stand in position A. You can do this during the test. What do arms straight out look like? Palms facing forward, arms straight out. What do arms at the side look like? Palms facing forward. Boom, boom, boom. Yes. Good job, you guys. Yes, it's letter B. Letter B, standing erect, facing forward, arms at your side, palms facing forward. Can you see how that gets a little soupy? You can't just rush through this. Well, you can, but likelihood is you may miss the best answer. All right. Arms straight out can be like this, like this. That's the wrong one. Okay. Next question. And on some of your MBLEx questions, there are only 3 answers. This is a question that samples a 3-answer question. The blank plane divides the body into upper and lower halves, upper and lower sections. The blank plane. We talked about this right this morning. I guess this afternoon, technically. The blank plane divides the body into upper and lower sections. So it divides the body in half, but what half? Let's see. Woo. Very good, you guys. A, the transverse plane. Now, your brain might say upper, lower, divides the body in half, that's sagittal. Sagittal is left to right. Transverse is up and down. Good. All right. Ready for one more? Okay. Tricky, tricky, tricky. Just warning you. The xiphoid process is blank to the navel. First of all, where the hell is the xiphoid process? Remember? Do you remember? Touch your xiphoid process right now. Touch it. I see some answers coming in. The xiphoid process, let's take a look. Xiphoid process, right? We have three parts of the sternum. The xiphoid process is the purple part here, right here at the bottom. Now, if I said your umbilicus, that would also mean your navel here. So we're talking here and here. The xiphoid process is blank to the navel. Let's see. Oh, I see some answers coming in. I see some answers. All right, so here's the crazy part. There's two right answers. But there's one answer that's better than the other. Let's take a look. The answer is superior. Why is the answer superior and not distal? Because distal and proximal mostly refer to limbs. Technically, the belly button, the navel, is distal, right? It's distal to the xiphoid process, but look at what the question asked. The question asked, the xiphoid process is blank to the navel. The xiphoid process is not distal to the navel. The navel is distal to the xiphoid process, but that's not the best answer. And that's where these questions get tricky, right? Because, wow, that sounds right. That sounds, like, yeah, it's distal. Well, the navel is distal, but we're asking the xiphoid process. So in relationship to the belly button, to the navel, to the umbilicus, give me the anatomical position of this xiphoid process. Does that make more sense now? I like where you're going. It's not because it jots out. It's just because it's higher than. And it's also the nature of the question. So the question is, let me read you the question. It's above on the body, right? Because it's above on the body. Yes, because it's above on the body, it's considered superior. Xiphoid process. Give me its relation to the navel. The relation to the navel is it's superior. If I had asked the navel is blank to the xiphoid process. Could it be distal? It could be. But in this selection, the best answer would have been inferior. Because if we're talking about the midline of the body, then we're talking about superior, inferior. Distal and proximal are mostly used for limbs. Now, you might get partial credit for the answer of distal, but not on this question, because we're talking about the xiphoid process. All right. Oh, we do have one more. All right, stick with me. We'll do one more and then we'll wrap it up. Pain on the bottom of the foot may be a pathology called blank. Pain on the bottom of the foot may be a pathology called blank. A, Achilles tendonitis, dorsal pain syndrome, plantar fasciitis, Morton's neuroma. Pain on the bottom of the foot may be a pathology called blank. Now, there's a distractor in here. Let me show you. Dorsal pain syndrome. It's not a thing. But our question says pain on the bottom of the foot, right? Bottom of the foot. Where's the dorsal part of the foot? The dorsal part of the foot is on top, right? It's a distractor. There might be something called dorsal pain syndrome, but I've never even heard of it. Remember the dorsal fin of the dolphin? All right. Pain on the bottom of the foot may be a pathology called, boom, plantar fasciitis. Plantar flexion, plantar muscle is on the bottom of the foot. You may say, Jody, why? It could be Achilles tendonitis. Is the Achilles tendon on the bottom of the foot? Nope. Now, technically, Morton's neuroma. Do we know what Morton's neuroma is? Look at all our answers. Hang on, let me check. Let me see. That's right. Dorsal is on the top, top, top. Good. Look at you guys. Kara, yes. Queen of Hearts, yes. Isabel, yes. Caitlin, yes. Exactly. Milka, yes. Good. Good, good, good. Yes, you got it. Good job. You weren't distracted by this Morton's neuroma. Morton's neuroma is on the bottom of the foot, but almost always it's behind the toes. Like at the base of the toes, right at the meaty part. What is that called? That part of the foot. So between the big toe and the ball of the foot, right? So right in there is typically where we see in between the toes. That's where we see Morton's neuroma. If you're not familiar with that, it is a pathology that is something you could be tested on. But good job, you got plantar fasciitis. And boom. Oh, we have a mishmash question. Oh, goodness gracious. Okay, mishmash means it's out of the blue. You didn't hear it today. It's completely off the shelf mishmash. All right. The saddle joint is found in what part of the body? The saddle joint. We did talk about movements of the body. We did not talk about the joints of the body. So, do you remember this from school? I don't even think I have any clues for you here. Oh boy, I know we'll do. There are the last navigating the body. If you want to go back and see the joints in the last video called Navigating the Body, we covered joints like all over the place. But saddle, it's only found in one part of the body. That'll be the clue I give you. Oh, Melissa remembered. It's only in one part of the body. Only appears in one part of the body. Oh, I see answers still coming in. Oh, there you go. There you go. Ready? Elbow is a hinge joint. I did give you a clue. All right. The elbow is a hinge joint, so that's not the right answer. That's a distractor. Ah, Queenie. Boom. The thumb. Yes. The thumb is the saddle joint. Here are your joints. We'll cover those another time. Here are the joints. So the saddle joint is a joint that looks like this. It looks like you're riding a saddle. Has nothing to do with the sagittal plane. Ball and socket is the shoulder, the hip. Ellipsoidal joint are your wrists. It looks like an M&M, the ellipsoidal joint. Hinge joints, those are normally easy for you guys. Knees, elbows. Hinge joint, like a hinge, like when you open the cupboard, like you open a cupboard door in your kitchen, there's a hinge joint. That's how that works. We've got gliding joints in the wrist as well. And the pivot joint is from occipital ridge C1, C2. They just pivot. So it's a joint that basically it's moving on a pivot. So that's moving on so that it stays, that C1 stays stable, and then it moves on the pivot. So that's a brief recap of the joints. But the correct answer was the saddle joint. It only appears in one part of the body, and that is your thumb. So, yay! Great work today. Good job. Thanks for hanging in there. This is a lot. It really is. It's a lot. And let's see, I see something in the chat here. Yes, thank you, Milka. You got it. Yep. Oop. All right, back to my. Okay. So thanks for hanging in there today. Oh my goodness, we covered a lot of ground. Uh, so I will sign off on the recording simply by saying thanks for being here. If you're listening to the recording later on, we have a lot of fun in class. We stumble through, we fail forward. That's a big concept with me, failing forward. If you get it wrong the first time, you're moving forward, you're failing forward. So don't even, think twice about wrong answers. That's how we improve. That's how we learn. How many of us learn? I want to say thank you. My name is Jody Scholes. I am your instructor for the MBLEx review class. We meet here every Thursday at noon. Join us on Patreon if you're watching us on YouTube. I'll put details about that in the description. But signing off for now and wishing you, holding the vision for you. Wishing means for me, holding the vision for you of celebrating with you after you pass the MBLEx. I'm holding that vision for you. I'm holding that space for you. It's why I show up on Thursdays so that you can show up in the world the way that your dream and therefore your destiny is calling forth. So thanks for being here. We'll see you again soon. See you again next week.